Every morning, without thinking about it, you put weight through your bones. You stand up from bed, you walk to the kitchen, you climb stairs, and something remarkable is happening in those bones that most people never think about. A constant, dynamic process of breakdown and rebuilding that has been running since the day you were born. Cells called osteoclasts are dissolving old bone tissue. Cells called osteoblasts are laying down new matrix. Collagen fibers are being woven. Calcium and phosphate are being crystallized into hydroxyapatite, the mineral lattice that gives bone its compressive strength. This is not a static tissue. Your skeleton is not a fixed scaffold. It is a living organ that responds to load, to nutrition, to hormonal signals, to inflammation. And when any of those inputs go wrong, the rebuilding process falls behind the breakdown process. And what you get is pain, fragility, stiffness, a joint that swells, a fracture from a fall that shouldn't have been serious, a knee that aches by 3 in the afternoon when 5 years ago it felt nothing. Most people assume this is simply aging. It is not simply aging. It is a biological cascade that has specific, identifiable, addressable causes. And understanding those causes is the difference between managing decline and actually reversing it. Let me be clear about what we're covering in this video, because the two words, bones and joints, are often used interchangeably, and they are not the same thing. Bone healing refers to the process of repairing fractures, restoring density, and maintaining the structural integrity of the skeleton. Joint restoration refers to reducing inflammation in the synovial tissue, protecting articular cartilage, restoring range of motion, and rebuilding the functional capacity of the joint space. These processes overlap. They share nutritional inputs. They respond to similar mechanical stimuli, but they are biologically distinct. And the reasons they fail are often different. So in this video, I am going to give you both. What actually heals bone tissue, what actually restores joint mobility, and the one protocol, simple, evidence-grounded, low cost, that addresses both simultaneously. If this is your first time here, welcome. This channel exists to fill in the clinical gaps, the information that doesn't make it into a standard appointment because appointments are short and the healthcare system is optimized for throughput, not depth. I'm not here to tell you the system has failed you. I'm here to tell you what the evidence actually says, clearly and completely, so you can make informed decisions about your own health. If that's the kind of information you want, subscribe. We are building a community of people who want evidence-based clarity without the spin. Come join us. I want to tell you about a patient I'll call Robert. Robert was 58 years old. He came in with bilateral knee pain, reduced range of motion, and what his previous physician had diagnosed as moderate osteoarthritis. He'd been advised to lose weight, take ibuprofen as needed, and consider a corticosteroid injection if things got worse. He followed that advice for 2 years. The weight didn't move, the pain didn't improve, and the corticosteroid injection, while it provided temporary relief, left him no better at 6 months than he had been before it. When I sat down with Robert and did a complete assessment, what became apparent was that the osteoarthritis diagnosis was accurate, but the treatment plan was addressing almost none of the modifiable drivers of his condition. His diet was pro-inflammatory, high in refined carbohydrates, low in omega-3 fatty acids, essentially absent of the micronutrients his body needed for collagen synthesis. His vitamin D level was critically low at 18 nanomoles per liter, far below the 50 to 75 range associated with optimal musculoskeletal function. He was sedentary in a way that was actively accelerating cartilage degradation, because cartilage has no direct blood supply and depends entirely on the pumping action of joint movement to receive nutrients from synovial fluid. And nobody had assessed any of this. The diagnosis was right. The intervention was incomplete. That's the gap this video is designed to fill. Let's talk about what bone is actually made of, because the biology is more interesting than most people realize, and understanding it changes what you do about it. Picture bone as a composite building material, something like reinforced concrete. The concrete itself is the mineral component, primarily hydroxyapatite, a crystalline lattice of calcium and phosphate that provides compressive strength. The reinforcing steel is the collagen framework, type 1 collagen, organized into fibers and bundles that provide tensile strength and flexibility. Neither component works without the other. Pure mineral without collagen is brittle. It shatters under impact loads the way chalk does. Pure collagen without mineral is too flexible. It bends and deforms under compressive loads. The genius of bone architecture is the combination, and both components require specific nutritional inputs to be maintained. When calcium intake is inadequate, the body pulls calcium from the skeleton, a process called bone resorption, to maintain blood calcium levels for cardiac and neurological function. That's how important blood calcium regulation is. The body will sacrifice the structural integrity of your skeleton to protect your heart rhythm. And when collagen synthesis is impaired due to vitamin C deficiency, chronic inflammation, inadequate protein intake, or hormonal changes, the tensile framework of bone weakens and fracture risk rises even if mineral density appears normal on a DEXA scan. This is one of the most underappreciated nuances in bone health. Density and strength are not the same thing. Now let's talk about joints, and specifically about why joint pain escalates the way it does. Healthy joint function depends on a thin layer of articular cartilage covering the ends of the bones, a material so well engineered that it allows frictionless movement for decades under loads that would destroy any man-made material. The coefficient of friction in a healthy joint is lower than ice on ice. That's not metaphor, that's tribology, the science of friction and lubrication, and it's been measured. Articular cartilage achieves this through a combination of its structure, a dense network of type 2 collagen fibers embedded in a proteoglycan matrix, and the hydrostatic properties of synovial fluid, which is produced by the synovial membrane lining the joint capsule. When cartilage degrades due to mechanical overload, inflammation, nutritional deficiency, or hormonal shifts, the proteoglycan matrix loses its water-binding capacity. The cartilage stiffens and thins. Friction increases. The subchondral bone beneath the cartilage begins to remodel in response to the changed mechanical environment. And inflammatory cytokines, particularly interleukin-1 beta and tumor necrosis factor alpha, are released from the synovial tissue, further accelerating cartilage breakdown. This is the cascade that produces the joint pain and stiffness of osteoarthritis. And the critical point is this: every element of that cascade has a biological address. Every step in that process is potentially modifiable. Drop your age in the comments right now, because the biology of bone and joint healing shifts meaningfully after the age of 50, and I want to make sure what I say next is specific to your situation. Here's why it matters. Before 50, the primary driver of bone loss is typically mechanical: inadequate loading, poor nutrition, insufficient vitamin D. The interventions are relatively straightforward and highly effective. After 50, and especially in women entering perimenopause and menopause, the hormonal axis of bone metabolism changes significantly. Estrogen is a direct inhibitor of osteoclast activity. When estrogen drops, osteoclast activity increases, bone resorption accelerates, and the balance tips toward net bone loss even in people with adequate calcium intake. The rate of bone loss in the first 5 to 10 years after menopause can be 3 to 5% per year, meaning a woman can lose 15 to 25% of her skeletal mass in the decade following menopause if nothing is done to address the underlying hormonal shift. After 70, testosterone decline in men produces a parallel effect, less dramatic in rate, but clinically significant over time. So your age tells me which part of this conversation is most relevant to you. Drop it below. Step 1. Rebuild the collagen framework, protein and vitamin C together. Collagen synthesis requires 2 things above all else: adequate dietary protein and adequate vitamin C. Not one, both. Collagen is the most abundant protein in the human body. Your bones, tendons, ligaments, cartilage, and skin are all predominantly collagen. And collagen synthesis is a vitamin C dependent process. The hydroxylation of proline and lysine residues in the collagen molecule cannot occur without vitamin C acting as a cofactor for the enzyme prolyl hydroxylase. Without that hydroxylation, procollagen cannot be cross-linked into stable collagen fibers. This is established biochemistry, Tier 1, well-established mechanism. Research from Stanford, published in the American Journal of Clinical Nutrition, found that consuming 15 grams of gelatin or collagen peptides combined with vitamin C 1 hour before exercise significantly increased collagen synthesis in tendons and ligaments compared to placebo. The dosing matters, the timing matters, the combination matters. For daily practice, aim for a minimum of 1.2 grams of protein per kilogram of body weight. This is higher than general dietary recommendations, but consistent with musculoskeletal medicine guidelines for adults over 50.
Add a source of vitamin C, not a synthetic megadose, but 200 to 500 milligrams alongside a collagen-rich meal or supplement. The combination is the mechanism. Step 2. Address the vitamin D and K2 axis. Calcium goes where it's told. Calcium supplementation without vitamin D and K2 is not neutral. It may be actively harmful. There is now substantial evidence, including a meta-analysis published in the British Medical Journal, suggesting that calcium supplements without concurrent vitamin D and K2 may increase arterial calcification, potentially increasing cardiovascular risk, even while they nominally add calcium to the body. Here's the mechanism. Vitamin D controls intestinal calcium absorption. Without adequate vitamin D, you can eat all the calcium in the world and absorb almost none of it. But vitamin D alone does not direct calcium to bone rather than arteries. That's the role of vitamin K2, specifically the MK7 form. K2 activates osteocalcin, a protein produced by osteoblasts that anchors calcium into the bone matrix. And it activates matrix GLA protein, which actively inhibits calcium deposition in arterial walls. In practical terms, vitamin D opens the door and lets calcium into the bloodstream. K2 is the traffic controller that sends it to bone rather than soft tissue. The therapeutic range for vitamin D3 is 2,000 to 4,000 international units per day for most adults with confirmed insufficiency, always with blood level monitoring. K2 at 90 to 180 micrograms of MK7 per day is the dosing range supported by the available evidence. Together, they make calcium supplementation both more effective and safer. Step 3. Use movement as medicine. Loading drives both bone and cartilage repair. This is the single most important step for joint restoration, and it runs counter to what most people with joint pain instinctively want to do, which is rest. Rest does not restore cartilage. Movement does. Here is the mechanism. Articular cartilage has no blood supply. It is avascular. It receives all of its nutrients, glucose, oxygen, growth factors, from the synovial fluid that bathes it inside the joint capsule. And that synovial fluid only delivers nutrients to the cartilage during the compression and decompression cycle of movement. When you walk, when you cycle, when you swim, the load on the joint compresses the cartilage, squeezing metabolic waste products out. When the load releases, the cartilage springs back, drawing fresh synovial fluid in. This is called the sponge mechanism of cartilage nutrition, and it has been validated in basic science research going back decades. A joint that doesn't move is a joint that is being starved. The optimal loading for cartilage, supported by research in osteoarthritis management published in journals including Osteoarthritis and Cartilage, is moderate, rhythmic, non-impact movement. Walking, cycling, swimming, aquatic exercise. 30 to 45 minutes per day of this type of movement has been shown in randomized controlled trials to reduce joint pain, improve range of motion, and slow radiographic progression of osteoarthritis. For bone,
weight-bearing and resistance exercise is the most powerful stimulus for osteoblast activity. The piezoelectric effect, the way mechanical deformation of bone generates tiny electrical signals that stimulate bone formation, has been known since the 1970s. Walking alone is beneficial. Resistance training is more powerful. Adding impact, heel drops for example, has been shown in research published in the Journal of Bone and Mineral Research to measurably increase femoral neck density over 12 months. Step 4. Reduce the inflammatory tide. Omega-3 fatty acids and anti-inflammatory nutrition. Inflammation is the fuel that accelerates joint destruction. The cytokine cascade, interleukin-1, interleukin-6, tumor necrosis factor alpha, doesn't just produce pain. It directly upregulates matrix metalloproteinases, the enzymes that break down cartilage collagen. This means that persistent low-grade inflammation is not just a symptom of joint disease, it is an active driver of its progression. Omega-3 fatty acids, specifically EPA and DHA from marine sources, are among the best-studied anti-inflammatory nutritional interventions. They work by competing with arachidonic acid for incorporation into cell membranes, which shifts the balance of eicosanoid production away from pro-inflammatory prostaglandins and leukotrienes. A meta-analysis of randomized controlled trials published in Seminars in Arthritis and Rheumatism found that omega-3 supplementation significantly reduced joint pain and morning stiffness in rheumatoid arthritis, and the mechanisms are relevant to osteoarthritis as well. The effective dose in those studies range from 2 to 4 grams of combined EPA and DHA per day. Food sources. First, fatty fish, 2 to 3 times per week, provides meaningful amounts. Supplementation, pharmaceutical-grade fish oil, tested for oxidation, is a reasonable addition for those who do not consume adequate fish. Diet more broadly matters enormously. The Mediterranean dietary pattern, rich in vegetables, olive oil, legumes, and fish, has been associated in epidemiological research with lower rates of osteoarthritis progression and lower inflammatory marker levels. It is not a cure, but it changes the biochemical environment in which your joints are trying to repair themselves. Step 5. The free bone and joint protocol, the daily 10-minute practice. Here is the specific, low-cost, home-based practice that addresses both bone and joint health simultaneously. Do this every day. It takes less than 15 minutes. Begin with 5 minutes of walking, brisk enough to elevate your heart rate slightly. This is not a warm-up. This is cartilage nutrition. The movement is the medicine. Then do 20 heel drops. Stand at a counter for balance, rise onto the balls of your feet. Then let your heels drop, a controlled fall, to impact the floor. Not hard enough to cause pain, hard enough to feel the impact travel up through your legs. This is a bone-loading stimulus. Research from Loughborough University found that 50 heel drops per day produced measurable improvements in hip bone density over 12 months. 20 is a solid starting point. Then do a 2-minute wall sit. Back flat against the wall, knees at 90 degrees. This loads the quadriceps, which protect the knee joint by absorbing compressive force, and it stimulates bone formation in the femur and tibia through sustained mechanical loading. Hold for as long as you can, up to 2 minutes. If 2 minutes is impossible, start with 30 seconds and build. Finally, 10 repetitions of a seated hip hinge from a chair. Stand up and sit down from a chair with control, keeping your spine neutral. This is a functional movement that loads the hip, knee, and ankle joints through their full range, pumps synovial fluid through all 3 joint spaces, and trains the neuromuscular control that prevents falls. That's it. Walking, heel drops, wall sit, chair stands. 10 to 15 minutes every day. Not most days, every day. The truth about bone and joint healing is this: your body has the biological tools to maintain, repair, and in some cases, restore musculoskeletal tissue at virtually any age. What it needs is the right inputs: mechanical load, anti-inflammatory nutrition, the specific micronutrients that drive collagen synthesis and bone mineralization, and the elimination of the inflammatory inputs that accelerate breakdown. None of this is complicated. None of it is expensive. All of it is supported by evidence. What it requires is consistency and the understanding that the biology responds to what you actually do, not to what you intend to do. Start with step 1 today. Your health is your responsibility, not the pharmacy's. I'll see you in the next video. Let me add one more dimension to this conversation that I don't hear discussed enough: the role of sleep in musculoskeletal repair. Bone remodeling and tissue repair are predominantly nocturnal processes. Growth hormone, the primary anabolic signal for osteoblast activity and collagen synthesis, is secreted in pulses during slow-wave sleep. If you are sleeping fewer than 7 hours per night, you are compressing the window during which your body performs the majority of its structural repair work. A study published in the Journal of Bone and Mineral Research found that sleep duration below 6 hours was independently associated with lower bone mineral density in adults over 50 after controlling for physical activity and dietary calcium. This is a biological mechanism, not a correlation curiosity. Poor sleep means less growth hormone. Less growth hormone means slower osteoblast activity. Slower osteoblast activity means the balance between bone formation and bone resorption tips further toward net loss. If you are doing everything right with nutrition and exercise but sleeping poorly, you are fighting the biology with one hand tied behind your back. Sleep is not passive recovery. Sleep is when the repair actually happens. And while we're rounding out the full picture, magnesium. It deserves its own paragraph because it is so consistently insufficient in the modern diet and so consistently overlooked in bone health conversations. Magnesium is a cofactor in over 300 enzymatic reactions in the human body. In bones specifically, it is required for the proper crystallization of hydroxyapatite, the mineral that gives bone its compressive strength. It is also required for the conversion of vitamin D to its active form, calcitriol. This means that if you are magnesium deficient, your vitamin D supplementation is partially ineffective because the enzyme that activates vitamin D, 25-hydroxy vitamin D 1-alpha hydroxylase, requires magnesium to function. The downstream effect is that calcium absorption is impaired, bone mineralization is impaired, and you may not understand why despite doing everything right. The National Health and Nutrition Examination Survey data consistently shows that over half of American adults fail to meet the recommended dietary allowance for magnesium. The RDA is 420 milligrams per day for men and 320 milligrams for women. Dietary sources include dark leafy greens, nuts, seeds, and legumes. Supplemental magnesium glycinate at 200 to 400 milligrams per day is well tolerated and bioavailable. It also supports sleep quality, which, as we just established, is directly connected to bone repair. These systems are integrated. Addressing one often amplifies the benefit of addressing another. One final thing I want you to understand about joint restoration specifically, because it changes how you should think about the trajectory of this condition. Articular cartilage has very limited intrinsic regenerative capacity. Unlike bone, which can fully remodel and replace itself, mature articular cartilage lacks the cell density and vascular access required for complete self-repair. This is why advanced osteoarthritis does not spontaneously reverse. But early and moderate cartilage degradation is a different story. Research on mesenchymal stem cell behavior in the joint environment, including studies from the Hospital for Special Surgery in New York, shows that under the right conditions, including mechanical loading, adequate growth factor availability, and reduced inflammatory burden, chondrocyte-like cells can slow and sometimes partially reverse cartilage matrix degradation. The key phrase is under the right conditions. The right conditions are what this entire video has been about. Reducing inflammation, providing the nutritional inputs for proteoglycan synthesis, loading the joint appropriately, protecting the subchondral bone. These are not exotic interventions. They are the biological prerequisites for whatever regenerative capacity your joints still have. Give your body those prerequisites consistently over months and years, not days and weeks. The timeline of musculoskeletal healing is measured in seasons, not in weeks.
But the direction of travel toward less pain, greater mobility, and more functional life is achievable at virtually any age, with the right inputs and the patience to let the biology do its work.